Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here to interview world-leading researchers, clinicians, and people with lived experience
to support your practice in being more evidence-based. Well, welcome back to the podcast, everyone. So glad that you could join us, and so glad, Marissa, to have you back on the microphone.
Thanks for having me. First one this year.
First one this year. That was your own doing, though. I mean, you decided to go on you tell everyone. What did you do?
I went in a caravan around the east coast of Australia for 5 months with my family.
And how many people in your family?
I've got 2 kids and my husband. So it's 4 of us in a very small space, but quite a wonderful adventure.
And you still love each other and you still want to be around each other?
Yeah, look, there's definitely moments. I'm not going to lie. Amazing.
It's so amazing. What an incredible adventure. We missed you, and how great is it that you can be back here in the studio again? Thank you.
My pleasure. Thanks for having me.
So good to have you. We also have a great guest today. We're so excited about this because we've never spoken about this area before. And when we're looking at the upcoming conference at the AACPDM in New Orleans, this particular person, our guest today, is featured quite heavily in a lot of the elements of this conference and has some very interesting papers that are coming out. So we're going to talk about that today. So we're so thrilled to welcome Dr. Arianna Trionfo from Nemours Children's Hospital in Delaware. Welcome.
Hello. Hi, Dana and Marissa. Thank you so much for having me today. This is tonight, I should say, given the time difference. Yes.
Yes. We were just commenting that it is a nighttime for you. You're looking fresh. You're looking great. You look like you're just starting the day. So thank you for staying up tonight to speak with us. We really appreciate your generosity with that because we want to learn so much from you in this area of orthopedics. So like I said before, you're part of this really impressive repertoire of work being presented at New Orleans coming up in October. So this is a great opportunity to talk about foot deformity for children with cerebral palsy. Marissa, how exciting is that?
I'm so excited because when I do assessments, I'm always looking at feet and walking, and we see kids across the lifespan. There's a lot to come from this. It's really exciting.
Yeah, so teach us. But let's tell everyone a bit about
I'm excited to discuss.
Oh, good.
This is an incredible bio. So let's tell everyone a bit more about you. So Dr. Arianna Trionfo is a pediatric orthopedic surgeon at Nemours Children's Health in Delaware. She graduated magna cum laude from Loyola College with dual degrees in biology and psychology, earned her MD from Rutgers, and trained in orthopedic surgery at Temple University before completing her pediatric orthopedic fellowship at the Children's Hospital of Philadelphia. Dr. Trionfo has led multidisciplinary clinics for neuromuscular and hip conditions, and her clinical focus includes cerebral palsy, hip dysplasia, and orthopedic trauma. She's a published researcher, mentor to future women in medicine, and an active member of POSNA, the AACPDM, and the AAOS, and the Ruth Jackson Orthopedic Society. Her work reflects a deep commitment to advancing pediatric mobility and inclusive care.
Oh, that
this
is
amazing.
Isn't it?
Thank you for that.
It's always nice when others do it for you.
It's a lot of work, and I've had a lot of support to get here.
I bet. And, it's just, it's incredible to bring in both the clinical aspect, which is huge in itself, as well as the research. It's not an easy thing to do, is it? But it's so important to keep moving the field forward.
It really is. It's quite the balance, but I think when you practice, right, it just leads to more and more questions, which is fun to try to answer.
Yeah, that's right. It's an adventure. Yeah.
I'm very excited to delve into your article and more about feet. But before we do, we're going to do an icebreaker question, which is standard here. And the question today is, when has language been a barrier in a situation for you? Dana, you look like, I'll give you time to think about it, but right. Dana, do you want to?
go first? I've got one that comes to mind that is my classic one that I tell people about. It is, we were traveling, it was about 10 years ago, and we went to Italy. And we went there with some family, and our family are from the Netherlands. And so no one speaks Italian, basically. And we had a bit of a problem with our Airbnb that we had. We lived in this beautiful place in Tuscany. There was a Nonna Maria, of course.
Of course, I have a Nonna Maria.
You have a Nonna Maria that looked after the place, and but she couldn't speak a word of English. So we were just signing a lot. It was super fun. But then we had a problem because there was no hot water upstairs. and we didn't know how to say that. So our family, our cousins, I'm going to blame him. I'm not going to name names. He goes to Nonna Maria, "Excuso, problemo, no watero, upstairso." And I was on the floor, like wetting myself laughing. And yes, I appreciate they put an O at the end of each one to make it Italian, but it didn't quite work. And we got there in the end. We got hot water. I don't know how we fixed that in the end. And this is kind of before we had Google Translate easily available as well. But, there was a problem and there was no water upstairs.
What was their response to that lovely language?
Her eyes were just wide open. That typical like, what?
No watero.
No watero. They were like, aqua,
That's great.
aqua. Marissa, do you have
That
one?
is awesome. Look, mine is in Italy as well. So my mum was born in Sicily. And when I was 15, mum and I went back there and we stayed with her auntie in this like remote village in Sicily. And my auntie, or my great auntie, only spoke Sicilian and I didn't speak a word of it. And I remember her cooking this big fresh plate of pasta and bringing it outside. And then all of a sudden, like 12 cats just come running and she puts the pasta down for the cats. And I was like, what is happening? But there was no way to be able to communicate this. So it was just this look of like, what is happening? And later my mum translated and asked, and every day she feeds the cats pasta.
Oh.
So she has like 12 semi-feral cats that are kind of her cats that she feeds pasta to. But at the time I was
You thought the pasta was for you.
I was really confused because we were jet lagged and it was our first few hours in Italy. But I'm talking, she did not speak a word of English and my Italian is terrible. So it was just a situation of like, what is going on?
That's a good scenario. Arianna, does anything come to mind for you?
So mine does not involve Italy.
Oh, nice. Okay, that's
mine
unique.
involves the one that comes to mind is when I was in medical school, I did an Operation Smile mission trip to a rural town in India, and no one, they spoke not much English.
Yeah.
And on my second day there, I was walking to the hospital and this swarm of children started following me. And it was a little bit disconcerting. I was in an area I never knew, and there was probably 10 or 12 kids trying to come up and, touch me, and they were looking at me, and I was obviously looked a little bit nervous. And then someone from our group came up who spoke the language and said, "Oh, do you just want to take a photo with you?" Because they had never seen anyone who looked like me, right? They were from this rural village. They didn't have access to, so they wanted, they'd never seen someone with blonde hair, blue eyes before. So yeah, that was, and then I learned I took many, many a photo in India.
Oh, they would have adored that.
That comes to mind.
That is cool.
It was great once I learned, but
Yes,
initially, I had no idea what was happening. Why are all these children following me? Yeah.
And that is the power of language. I
That
think we've
is,
summed that
isn't
up
it?
beautifully. That
Yeah.
question is, and
Yeah.
obviously you have nonverbal, we can communicate and you obviously got that across eventually, but it's that initial thing, language is obviously.
I have no idea what's going on right now. Yep. And there's always someone on that side that doesn't know what's going on. So but it's always the whites of your eyes and the raised eyebrows. It's the same response. I think that's always the case.
Yeah.
Well, speaking about different languages, I feel like orthopedic surgery is like a slightly different language. See what I did there?
No.
Oh,
I like that. That was a nice
that was
segue.
not bad, yeah. And it's not absolutely true, but I felt it was kind of nice to lead into it. So we have many questions for you to help us to understand this area more, because it is a little bit of unless you're in the surgical room, like we're not actually seeing any of this. It's always just we don't really have that kind of appreciation as physios. We see it at the other end, really, once we start doing the rehab.
And I feel like it's so amazing what I guess you and your colleagues do as orthopedic surgeons. And we often have done, therapy and rehabilitation for children after either multi-level or single-level surgery, at, a number of different ages. And I think, combined with the post-operative rehabilitation, the outcomes are just astounding. And so, a lot of respect for what you do. And I love that we're going to delve more into feet, because hips we've spoken about a little bit, but feet we haven't so much.
Yeah. Well, I tell all of my patients when we're entering into surgery, right? It's a three-way relationship. It's my surgery, it's the patient and their compliance and their attitude, and it's their therapist.
Yeah.
And it's a three-way street, and it's so important.
That's
Love
beautiful.
that. It's wonderful.
So I value what you do too.
Wonderful. Team effort.
Thank
There we
you.
go.
Yeah.
All right. So to start off with, before we delve into your article, can you explain to us what foot deformities are most commonly seen in children with cerebral palsy?
Oh, yeah, that's an easy one. I can do that. Right. So, really, there are three main deformities. You have your equinus deformity, which is really where your foot is stuck in that plantar flex position, kind of that toe walking position. That's a
Yeah.
pretty easy one. And then your two more common ones that often end up needing surgery are your planovalgus foot, right, which is the fancy word for a flat foot, right, where the heel is in a little bit of a pointing outward position, and the toes face outward,
Yes.
right? And then you have your equinovarus foot, which is the opposite, right? Think more like a club foot, where the toes are pointing inward towards the body, and kids tend to walk more on the outside part of their heel. So those are your two most common, foot deformities that end up needing surgical correction in a certain percentage of our patients.
Right.
Do you have set ages? I'm delving back into this, but do you have certain ages that you would delve into surgery? Because I know with hips, we know, there are different protocols and different ages when you might do VDROs or hip adductor releases. But for feet, what ages do you commonly intervene?
So foot deformity in our patients with neuromuscular conditions can be rather unpredictable, right? So especially before the age of 5, we don't really know where those kids are going to ultimately land on the spectrum of planovalgus to equinovarus. And so we really try not to intervene too early because we don't know what that natural history is going to be for those patients. So planovalgus foot is really more common in our patients with spastic diplegia, right, or bilateral involvement, whereas equinovarus feet can be more common sometimes in our unilateral patients, as well as our non-ambulatory patients. And so we really try not to intervene surgically too early, right? We do really rely on therapy, stretching, bracing, up until the point where kids just can't tolerate it anymore. So we really try to wait until that sort of adolescent period before we intervene surgically.
Sure.
And I know you touched on then about some differences between whether kids are ambulatory or non-ambulatory and the differences in foot positions, but can you expand on that a little bit more about what differences we might see?
Yeah. So in our diplegic patients, or our kids who have bilateral involvement, who are a little bit higher functional levels, right? So your GMFCS 1s through 3s, we commonly see patients have flat foot, that planovalgus foot deformity. And in contrast, our patients who are non-ambulatory, or our GMFCS 4s and 5s, have a tendency to have more equinovarus feet. That is not a hard and fast rule, right? You can see both foot deformities in patients with any functional level, but those are definitely some of the tendencies that we see. For our kids who are ambulatory, a bad foot deformity ultimately can lead to pain, and it can make walking less efficient, right? So we refer to that as lever arm dysfunction, right? So the idea is your foot pushes off of the ground and acts as a lever to propel your body forward. And if your foot is not in an optimal position, it's more difficult to generate that power to walk and move your body forward in space. And then when it comes to our non-ambulatory kids, oftentimes they rely on bracing, right, to help them with standing transfers and being in a stander. And ultimately, if they're not able to tolerate that, that can really impact, their daily life and their ability to participate in some of those activities.
Huge.
That was a great description. Thank you so much for that. That was lovely to follow. Some more questions I have from that is there much of a difference between kids who present with more spasticity versus dystonia on foot postures and positioning?
Also a great question. And again, the natural history is really variable. So it's, I would love to say, if you have a lot of spasticity, you are going to have a planovalgus foot versus dystonia leads to equinovarus. And that's just really not the case. We truly see a mixed bag depending on presentation. And muscle tone or movement disorders have not been shown to be predictive of the type of foot deformity that patients get.
Right. Does the type of tone that presents impact maybe the number of surgeries they might need? Like, do you tend to have to do surgery once? Like, it's more like preventative not preventative. It's not done preventatively. It's done more as the child gets older and you can see the foot position. You're not sort of treating it ahead of time. You're treating it in response to what the foot's doing. So if you're doing it later on, more in adolescence, does it mean that you're less likely to have more surgery later on? Or, yeah. Does that make sense?
Oh, that's a wonderful question, and one that we don't have an answer to, but I'll leave you with a bit of a cliffhanger because that is a study I'm working on right now. So save it for AACPDM of next year.
Okay.
Hopefully we'll be ready to present that.
Oh, gosh. Good. Okay.
But so to answer your question, the first part of your question, I think, is patients who have dystonia can have really unpredictable outcomes.
Yeah.
And we do know that their response is not always exactly what we would think, right? So a foot that was planovalgus that has correction can oftentimes overpull into equinovarus. And so that's a discussion that I have preoperatively with patients who have a known movement disorder like dystonia. But in a patient who has more classic spasticity, right, we like to think that this is a definitive surgery in a lot of cases. Right. We try to wait until adolescence and hope that it doesn't recur. And that's, a little bit of early, what's the word I'm looking for? We'll get into it with my study, but that's what it shows too.
Yeah, awesome. That's so cool. That's really, really cool. Can we ask a little bit more about what surgery actually looks like now? Like, what do you actually do for these particular presentations?
So wonderful question. It is not a one size fits all, right? So a lot of our patients are having surgery as part of a bigger procedure, right? So we do a lot of multi-level surgery in our neuromuscular patients. When it comes to foot deformities, though, if I just focus on that part for the sake of the question, a lot of the times in our patients who are really good ambulators, right, our GMFCS Is and IIs, we're trying to avoid going into any bony joints. Any joints, and we try to just do bony surgery with osteotomies and soft tissue procedures.
Right.
For our kids who are, have higher GMFCS levels, meaning our 3s, 4s, and 5s, we tend to do bony fusions because we feel that those last a little bit longer. So that's where we take two bones that were separate in the foot and we combine them and turn them into one. And so in either case, it involves multiple cuts in the foot. And, we have to usually make multiple incisions with multiple cuts, and it involves hardware to hold the bones in place and sometimes grafts to help with that correction.
It's amazing.
Just the tools that are involved with that, but also just the size of the bones in the feet, right? Like they're not big. And also for a lot of these kids who are not weight bearing, I imagine they're even smaller. Does that have any, like what's their bone density like? For those non-weight bearing feet?
I was going to say it's not so much the size of the bones, but it's the strength of the bones, right? Yeah. So we know a lot of our kids, and that was one of the factors that we looked at in this study, was osteopenia or osteoporosis, right? We know a lot of our patients who are non-weight bearing do tend to have bone health issues. And so that was a big concern of ours, in terms of bone healing and, maintaining the correction that we got with surgery. So a lot of these things come into play when we're deciding what type of surgery to do and what type of fixation to use.
Wow. Very interesting.
It's amazing. Do you often, I know you talked about it as in terms of multi-level surgery at times, when you're looking at the foot and you're looking at that planovarus or equinovarus, is it often combined with muscle lengthening or some other sort of soft tissue surgery as well in terms of the foot?
Almost always.
Okay.
It is associated with lengthenings, right? So it really depends on the patient and the presentation. But commonly, when you have a planovalgus or a flat foot, your heel cord is shortened. So when you correct, because of the valgus position of the heel, and so when you correct it into a more neutral position, that heel cord becomes tighter. And so we oftentimes do a gastroc recession in a lot of these patients. We also do the perineal lengthening at the same time to try to correct that pull into abductovalgus. So yes, we do soft tissue lengthenings and tendon lengthenings almost always at the same time.
Amazing. It's amazing to think of the foot. Obviously, like you said, that lever arm, it's critical for what's going to happen further up, even though it's the most further away.
It's so important.
And looking at the combination, the power of, you've got obviously the bony deformity, but you've got the muscle imbalances as well. You've got the varying tone. It's highly complex and highly individualized, I guess, like you said, depending for each child.
It's so amazing. And I just always think when you have an injury to your foot, any of us might have an injury to your foot, even if you stub your toe and you're walking slightly differently, and then the impact of your big toe even, of how you actually push off. Like when you think about the mechanics and that how it impacts your function, your quality of life from something that happens so distally, it's just so vital. And I think sometimes when you're looking at the big picture, looking at children with cerebral palsy, you're looking at how they can ambulate, keeping them functionally, making sure they've got the function, but having the physical ability to engage in mobility and participating. All of those require a body that's not in pain and a body that's able to actually use the mechanics that it's been given. Otherwise, it's just so effortful. So that's why like you said, I love what you said right at the beginning, Arianna. It's just that the team is so vital, right? Nothing can happen in isolation here, can it?
No, most certainly it cannot, right? And I think foot surgery, the feet are literally the base upon which we move around in our world, right? They're so important. And having deformities can really impact a lot of our patients. And so I think that's why we started this line of inquiry or this line of research for me started at the feet, because I think that's really a foundational component.
Yeah, that's so good. Well, I've got more questions regarding to some questions I think families have, but let's delve into this article a bit more now, which is your abstract that you'll be presenting in New Orleans. And so your team, like you said, looked at this specifically. So just starting broadly, what was your specific aim of this particular work that you were doing?
So, really our big question was, is it safe to let kids walk right after foot surgery? And I'll tell you, the idea for the study came when I came to Nemours just under 4 years ago. Dr. Freeman Miller and Dr. Wade Schrader were doing these major reconstructive surgeries and then letting kids stand and walk right away, which I will tell you was very different from my training and my practice prior to coming to Nemours. And I said, whoa, what's going on here? This is very different. And, their outcomes were great and patients had wonderful outcomes. And I said, well, we should study this, right? It has been something that Dr. Miller started doing decades ago. And I said, well, we should really look at that, right? And look at the outcomes, because it's not mainstream, but it can make such a big difference, not just for our patients, but for caregivers. And so that was the big question was, is it safe to let kids walk after a flat foot reconstruction? And so what we did was we compared patients who were allowed to walk right away to those who were not allowed to walk right away. And we said, well, was there a difference in the complication rate?
That is such a good question.
That's the question.
That is such a good question. Now, before we get into the answer for that, can I ask, it sounds like there's such a variance with regards to post-op protocols. Is that mostly based on experience, how you've been trained? Like, where does that come from and what we recommend?
It's a great question, and another one with a cliffhanger, because I have an article coming out on that. It should be published in a few months.
Arianna, so many good things.
All over.
I love it.
So we did a survey of members of the AACP, of orthopedic surgery members of the AACPDM, asking for their protocols. because they vary so widely, not just for foot surgery, but for all levels of surgery, for what we do after pelvic and hip and knee and tibia. And there's really no good evidence upon which our recommendations are based. I think a lot of it just comes from dogma. It comes from where we were trained. It comes from, we're extrapolating from other conditions and, typically developing patients and such. So there's not a real robust body of literature to support what we do in the neuromuscular population. Yeah. And so I think these protocols just get passed on, right, in training, and then you do what you're taught because that's what your mentors and the giants who came before us did. Yeah. Right. And so the typical period of non-weight bearing after foot surgery is anywhere from 4 to 8 weeks of non-weight bearing. That's pretty standard, at least across North America.
Wow. And that is a long time.
That's
for a child that's normally ambulant, like 4 to 8 weeks is a big difference in their life, but also what that means from like a muscle atrophy perspective. I remember like the biggest, aha moment I got when I was a young physio was after you have, the literature on ACL reconstructions and you're immobilized for just a short period of time and the VMO just decreases in size, like significantly so, and even more so for our kids with CP, right?
Right. So when you're starting, I think, from a level where you don't have as much muscle strength and as much endurance, right, that hit might be even harder, right? Yeah. I also think there's a significant burden on the caregiver, right? And that's something that we don't talk much about. But, to tell a parent or a caregiver, hey, your child is not allowed to stand, right, for standing transfers or can't move around the home, that's a big burden on not just the patient, but the family and caregivers.
Particularly if they're, like you said, a lot of the foot surgery isn't happening to adolescents. They're heavy. It's not, you can't just lift them. They're needing new equipment. And especially, with foot surgery often being combined with multi-level surgery. And if the foot, obviously you've got to combine your post-op recommendations across the board, depending what surgeries you've done. But if the child is not allowed to weight bear purely because of what's happened at the foot, which may, be warranted or may not, depending, this is where we're headed, being sedentary, having to sit and not weight bear for that period, we really see that deconditioning.
You do.
Especially for kids GMFCS I who are often on a cusp of just maintaining their mobility, particularly entering adolescence. Yeah. So I get excited because I think, imagine if we could get these kids up. Yeah. Obviously you guys are doing the operation. You need to make those calls. But the impact not only on the caregiver but on their long-term recovery and the time that it takes could make a massive difference.
Huge. Really important.
Yep.
So Arianna,
and I think that's what Dr. Miller saw years ago, right? And now I'm just reporting on it.
I love that. So can you tell us a little bit about the participants that were involved in this study?
Yeah, of course. So we looked at 135 ambulatory patients, right, meaning GMFCS I through III, who underwent Planovalgus foot reconstruction. The criteria for inclusion were that they had to have a gait analysis. We are lucky enough to have a wonderful gait laboratory at Nemours. And so these patients had a gait lab done within a year and a half preoperatively, and then a postoperative one done within 3 years at minimum after their surgery.
Oh, wow. And why was that such a crucial part of your inclusion, having the gait analysis?
So we at our institution heavily rely on gait analysis to guide our surgical decision-making, right? It gives us such a wonderful dynamic view of the patient, right? And it really breaks it down by segment. But when it comes to measuring foot deformity, we actually really rely on the gait lab and in particular the pedobarograph, right? Which is the foot pressure. And the reason we rely on that maybe more so than our x-rays are because when you're watching a patient walk, it's a dynamic measure, right? Yes. So you see what's actually happening to that child's foot when they're moving, as compared to an x-ray where it's a static image. It doesn't really give you as much information on what are the position of the bones when the patient's walking, right? So we're able to look at the foot pressure, and it kind of tells us, well, look, when this child takes a step, there's a ton of pressure. This can't be comfortable, or this is important for degeneration of the foot, right? So we think it's a really kind of real-time dynamic look.
Allows you to reassure in your mind, I guess, gives you that confidence for those very complex decisions that you're making in your preoperative clinics.
Yes, I agree. And it can, and sometimes something that looks really, really terrible doesn't show up that bad on the gait lab, right? Or is not really a functional issue. So it can go both ways.
Yeah, of
It really
course.
does help us to inform our decision making.
Yeah.
Love that. Now, you defined complications across 3 different time frames in your study, short, mid, and long term. Can you elaborate on these and why those time points were chosen?
Yeah, of course. So the short-term complications were defined as those that took place less than 6 months, and we define those as a non-union, hardware failure, or infection requiring acute return to the operating room. Midterm was defined at by the correction status. So how good did we do, right? Did we correct the foot? Did we not correct it very well? Or did we overcorrect it into more of a equinovarus position? And then lastly, that long-term follow-up, on average, we followed up midterm was 3 years. And then our long-term follow-up looked at patients on average of 8 years after Planovalgus. But we had really long-term follow-up in our cohort, which I think is phenomenal. But what we said was, well, do these kids end up needing to come back again, right? Do they need another reconstruction, or does it last, for what we defined as the long-term? And so, from a surgeon perspective, if you're going to make a change in your postoperative protocol, you want to make sure that you're not going to cause any acute complications, right? And we worry about, is the hardware going to break? Or is our correction going to loosen? Are the bones not going to heal? If they're walking and they're rubbing in the cast, are they going to be more prone to infection? So that's why we selected those short-term outcomes. In terms of the midterm, we were worried, if we allow these kids to walk, does that affect the correction status, right? Are the kids who walked more likely to be undercorrected because it goes back to the original deformity as compared to the kids who didn't? And then ultimately we want to say, do we need to come back here again, right? Which I think is really important, not just from a surgeon's perspective, but to inform families about, right? To set the expectations for, hey, we're really hoping this is one and done versus, hey, you should anticipate coming back to the operating room in a decade, right? So that's how we define them, and that's why we chose them.
That's brilliant. I love that, all of that, because that answers so many consumer questions. Parents would ask these questions all the time, right? Like that we want to know whether this is the right time to do it, and will this mean this for later on. Can I ask a question on the actual surgical procedure? Given it was all done within the same hospital with the same mentors and guidance for the procedures, does that mean a lot of the procedures are quite similar? Like, how did you control for variance in different types of procedures potentially in something like this?
So we weren't really able to control for that, right? This is a retrospective look, and so it has the limitations of a retrospective study. But in general, I think I mentioned this earlier. What we do typically is our kids who are really high functioning ambulators tend to have more osteotomies versus our patients who are a lower gross motor functioning. They tend to get fusions. And so it's not a hard and fast rule, but we included all of those in this cohort. We really did not differentiate, but cliffhanger, that we're working on that study too.
Oh my gosh, there's so much good stuff.
This is just that, right? A good question begets more questions. And so here we go.
Great.
That's right. Before we get into the results, I feel like we've cliffhanged that one for a little while. I know we want to get to that, but the immediate weight bearing, I feel like I need to clarify that in my head. What does immediate weight bearing actually look like? Like, are they in a brace? Are they literally how many days post-op? Are they on their feet? Like, what does that mean?
Oh, that's such an important question. So most of our patients are in a cast right after surgery, and we allow them to get up and stand literally on postoperative day 1. And so we put special rubber bottoms on our casts that just make it easier for our PTs to help these kids, be able to stand up with some traction. And a lot of our patients are doing some, high intensity inpatient rehab. And so they're really working on standing right away. And so usually within a couple of days postoperatively, we're getting them up, at least getting, them standing for transfers. They may not be, walking multiple steps at a time. But that's ultimately the goal. But literally a few days after surgery, they're getting up and standing on their feet.
It's always such a spin out, isn't
Yeah,
it?
it's pretty
It
awesome.
really is. Like,
is.
you know, you always think it just needs to heal. And that's very traditional thinking as well. You know, like you've had surgery, you just need to rest. But, you know, everyone's now talking about you've had surgery, and it's always those physios. Us physios come and see you in the inpatient and we're like, okay, time to get up.
It's not the easiest job. No one told me that as a 21-year-old when I was getting people up post-operatively day one.
No one wants to do it, do they? But you're like, sorry. All right.
The promise is good for you.
That's right. That's right. And the evidence will speak for itself. But let's get there. Let's talk about the results.
Now I'm so excited. Okay, so key findings. Just been waiting for this moment. But what were the most striking results you found when comparing the immediate weight-bearing group to the non-weight-bearing group?
So, you know, if I could summarize it in a headline, it would say letting kids walk right away is just as safe as keeping them from not walking, right? What we looked at is, you know, at short-term, midterm, and long-term follow-up, there were no difference in the complications, which I think was pretty phenomenal.
Yeah.
You know, if I'm being critical of our own study, right, we are slightly underpowered, you know, in terms of the comparison, because at our institution, the standard is to let kids weight bear right away.
Yeah.
So we had 84% of kids who were allowed to weight bear right away versus only 16 who were not. And that was purely based on surgeon preference. We really critically evaluated those charts to see if there was a medical or, you know, or surgical reason.
Sure.
But overall, our complication rate was so low, really, really low. There was no infections. We hit the nail on the head about 50% of the time in terms of our correction. We undercorrected some of them. And not many patients needed to come back at long-term follow-up, right? Which means the surgeries we did lasted for on average of 8 years, which was pretty awesome.
That's amazing.
That is such a fantastic result.
Yeah.
That must have been so fun to punch the numbers for that and go, whoa, look at these results.
It was really awesome, right? There was a little bit of nerves going into it saying, I hope it's as good as we perceive it to be. You know, and it was really nice to have that validation. Yep.
Was there any really noticeable trends in terms of like a particular GMFCS level or surgery type that, you know, I know you've said with confidence that there was no complications, but would there be one particular type of surgery or one particular level of GMFCS that you would have more caution with, or was across the board?
So nothing like that came out of our study. The only thing we found is that the worse the foot to going into surgery, right? So meaning the worse their foot pressure showed their deformity was, the less successful we were in correcting it fully.
Right.
So, you know, those feet that were really, really bad, we tended to undercorrect those a little bit.
Right.
That was really the only trend. But outside of that, we did not see a whole lot of trends or difference between any of the groups.
Incredible.
That is just so interesting, isn't it? And I think that's just so reassuring on so many levels. One, you know, when there's talk about surgery, timing is always part of that discussion, and the idea that this is happening. I think the mean age, I mean, look back in the paper, something like 12 years or something. So it was, you know, they're older children, and that you're looking at the complication rates in terms of long term. That's fantastic. Like, that's taking them through to adolescence and they can still weight bear. That's fantastic. What does this mean now for you as an orthopedic surgeon within your practice? What do these results mean now?
Well, so it really supports what we're already doing, right? And it makes me even more confident in our hospital's practice and our postoperative protocols, right? And I think this study has a lot of potential, you know, clinical implications, right? You know, you talked about the impact on children being able to, you know, get up right away, to not experience that muscle atrophy, to be able to stand for bone health reasons, for mental health reasons, right? As well as the impact on the caregiver. And so you know, for us, this is just the tip of the iceberg. You know, I said I started with the feet because I felt like that was the basis of all of it. And we're moving on to look at the outcomes with other parts of our multi-level surgery, right? To look at the impact of weight bearing. And, you know, I really hope that this catches on, right? Because I think it has a lot of potential benefits.
Yeah. And that's the power of going to conferences, right, and presenting this work to a large body of health professionals that are just want to look at the evidence to direct their care, right? And this is a great opportunity to bring everyone together and raise awareness about this. So, yeah, congratulations on this work. My goodness.
I agree.
That is so exciting.
Thank you.
Yeah.
I'm very excited about it.
Yeah, I can see that. It's great. I love it.
Okay, so where to from here is, I know you've given us some teasers, but can you kind of bring it together just so I actually can map in my brain?
When we need to talk to you next, which paper we need to look out for, all that stuff.
So it's quite incredible that you combine the orthopedic work and your research.
Yeah.
This has really sort of become like a passion project of mine, right? Looking at sort of the rehab process afterwards, because as I said to you, I've maintained this throughout my training and my practice. I really believe this is a three-way relationship, right? And my surgery is only part of it, but it's what happens afterwards, right? And it's the relationship you guys have with the patients. And so I would love to see, we're doing a lot of work at our hospital looking at mobility across really the whole perioperative course. So we have a lot of wonderful therapists who are working on getting patients involved with sort of prehab, similar to that ACL concept. We're doing that with a lot of our neuromuscular patients. And then we're taking them through surgery and having them walk right away. We're collaborating with a lot of our rehab teams, and then, going that's the clinical side where we're going forward with it. But then the research side, I gave you so many teasers, but there really are a lot of things coming in the pipeline, looking at the implication of weight bearing on, tibial osteotomies and femoral osteotomies and all of those other surgeries we do commonly that a lot of places across the world don't allow patients to weight bear right away. Right. So,
wow.
Research is power.
It's so great. And the impact that that's going to be able to make on so many people is phenomenal. And, funders love this as well. It's less time in hospital, it's important.
Less equipment, less burden of care. It's huge. Right. There's so much. This is
Yes, funders, pay attention to this one too. All right. Well, let's wrap all this up really nicely now in our next segment, which is called Tell It to Ed. Let's go. Ed, as you know, is our producer. He doesn't have a background in child health, nor has he really heard too much conversation about surgery before. So this will be an interesting one. So before Ed asks his question to you, Arianna, I'll get you to summarise this area in about 60 seconds or so. And Ed, you'll have time for one question. Take it away. Take it away.
Should I go now?
Yeah, go for it. Go for it. Yep, go for it.
All right, Ed. So if I have to summarize this, I'm going to say children who have cerebral palsy often develop flat feet, and it makes walking hard. And so surgery oftentimes fixes this, but recovery can be really brutal if the kids are kept off their feet for several weeks. So our study asked the question, do they really need to stay off of their feet? So we followed 135 kids from before surgery to after surgery, and we compared those who walked right away to those who didn't walk for several weeks. And the ones who walked right away did not have any higher complication rate than those who were made to stay off of their feet for a while, and their feet improved just the same. So that means recovery has the potential to be easier and faster, both for the kids and their families, without a lot of added risk.
That was such an impressive summary.
Yeah.
Wasn't it?
Amazing.
Gosh, captivating. That was so good. Ed, over to you.
Well, Arianna, I think I've actually said this in the previous podcast episode that we recorded. And my incredible hosts do an incredible job just kind of facilitating the conversation, but invariably as the conversation proceeds, the questions that I'm listing on my computer in front of me get crossed off as those questions get asked. So I don't get left with a lot, to be honest. But I guess
they're too good.
Thanks.
The conversation's been brilliant, and obviously the immediate weight bearing, that's quite an eye opener for someone like myself. I don't know too much about the human body in general. I'm an IT guy, so you'll have to forgive me.
Very helpful, though. Very, very
I don't know much about IT.
Yeah.
So.
Okay. But I guess I kind of want to play slightly devil's advocate to this. So this seems like an incredibly new way of thinking about how all of this should be handled post-surgery. So I'm just wondering, for people who may be very cautious about adopting new implementations or new discoveries or this particular research, why would they hold on to how it's always been done? I guess you've given a lot of the benefits as to the immediate weight bearing and, possibly with, kids with CP losing their mobility if they spend a lot of time off their feet. And I can obviously see those benefits, but why would someone try to be cautious about this? And what would be your response to that?
Well, I think because our study is slightly underpowered to detect a true difference, right, we would need even more numbers. So ideally, right, we would collaborate with another institution whose standard of care is to not let kids weight bear, right? And we would be able to compare those groups with even more numbers. And so that is an idea in the works, but a little bit more challenging to implement, right? But so, I think people who would not be ready to adopt this are people who would just want a little bit more robust evidence if they're being really, really critical, right? But I think the low complication rate overall is what we really hang our hats on, right? So, the complication rate in both groups was so low. I think if I'm being really, in terms of my practice, if patients are not true neuromuscular patients, I don't let them weight bear right away, right? I have a couple of kids who present with different conditions, and I've tried to let them walk right away, and it's just a different ball game altogether. So I would still caution some clinicians, if you're not treating a patient with a neuromuscular condition, don't apply anything we've talked about today. This only applies to our patients with CP.
Yeah. That was a great answer. Good question, because it's all about adoption as well, isn't it?
Yeah.
And the readiness for adopting new information, because we can put it out there, but it's also that next step. Thank you so much for staying up so late to speak with us today. Marissa and I, you can see we're a bit giddy with excitement with all the information you're providing for us today. It's just so wonderful to know this research is being done. To all of those listeners out there who are going to be headed to New Orleans to the next conference in October, I would really encourage you to check out some of the work that Arianna's presenting with her team as well. There's actually a lot. You guys have got a lot of stuff going on with an educational session as well. So if there's questions that Ed or us didn't ask, maybe go find them and ask them yourselves at the conference, which is the power of going to a conference. And if you want more information, of course, we'll put links for everything we've spoken about today on our website, researchworks.net, as well as researchworks.academy, if you want to look at more of this information in the interactive AI scene as well. But Arianna, thank you so very much.
Thanks to both of you. This was wonderful. And thanks for your podcast and getting the information out. This has really been a wonderful experience.
Thank you for staying up late for us. Look, and just
my pleasure. It's bedtime now. You guys have a wonderful day. And if you're in Philadelphia next year, please reach out to me. I would love to meet up and show you around.
I cannot wait. That I'm definitely going to be there. So I can't wait to talk to you more about the next lot of research as well. So stay tuned, because we will be contacting you now that we've got all these teasers. But to all of our listeners, I hope you really enjoyed that as well. And we'll talk to you all again really soon. So goodbye for now. Bye, everyone.
Bye.